Refractory headache patients can be difficult to treat and may experience more disability, which creates a challenge for headache specialists. Therefore, peripheral nerve blocks may be a good alternative method in these patients due to its minimally invasive nature. And in recent years, interventional methods have come to the front in refractory headache patients who don't respond to medical treatments. Although local procedures other than Botox have not been subjected to blinded placebo-controlled trials, the use of interventional techniques in the management of different types of refractory headache is a well-established practice among headache specialists. So what are the indications for peripheral nerve blocks? Nerve blocks can be used for acute attack management, bridge therapy, or preventive treatment in various headache types, including intractable headache disorders. Those treatments should be considered in refractory patients with a poor response to pharmacological management, and patients with a late response to attack treatments, or patients with complicated migraine, refractory headache attacks in brainstem aura, or hemiplegic migraine, and patients who develop intolerable side effects from the pharmacological treatments, who have comorbidities such as hepatic and renal failure, are good candidates for those treatment options. Nerve blocks can be also performed safely after 15th week of pregnancy, in pediatric age group, and in medication overuse headache for bridge therapy. Which methods in which headache disorders? Till now, there is no consensus about the procedure of nerve blocks. The methodology, the type, and the anesthetics used can vary. A wide variety of procedures have been described for a diversity of headache types, including chronic migraine, cluster headache, cervicogenic headaches, chronic daily headaches, trigeminal neuralgia, occipital neuralgia, and others. Cluster headache and migraine were the most frequent headache types for the indication of occipital nerve block. Following the two randomized controlled trials demonstrating the efficacy of GON block in cluster headache, this form of treatment, including steroid, was accepted as the only Class A evidence treatment in cluster headache patients. So given that approved medications in chronic migraine are effective only after a lag period, GON blocks may be an alternative treatment options serving as transitional therapy with rapid efficacy. GON blocks are inexpensive, relatively easy to administer, and have been used for decades in various types of headache disorders, but there have been only 4 randomized controlled trials of their use in migraine so far. Although many headache specialists have provided evidence of the substantial clinical efficacy of GON block in chronic migraine, the lack of adequate randomized placebo-controlled studies have discouraged clinicians from performing greater occipital nerve block in these patients. However, we know that only 44% of chronic migraine patients can use preventive medications regularly. Thus, it's our belief that greater occipital nerve block should be performed in patients with chronic migraine and frequent episodic migraine at least once as transitional therapy and even prophylactically, to decrease the dose of medication associated with poor compliance because of their side effects. So occipital neuralgia is the only headache type in which the response to greater occipital nerve block is among the diagnostic criteria in these patients. Our experience has shown that headache patients with cluster headache and medication overuse headache are likely to obtain the greatest benefit from these procedures as rescue therapy. In chronic migraine, we perform GON block at least once and consider botulinum toxin treatment if we don't obtain sufficient benefit after the greater occipital nerve block procedure. And we also use GON block as prophylaxis in pregnancy, as most medications cannot be used due to the side effects. We also perform GON block bilaterally, except in cluster headache, where the nerve is applied to the side of the pain. If the pain is refractory to GON block, other cranial nerve blocks are offered in addition to GON or LON block if tenderness is palpated in the corresponding areas of the nerves. In a survey conducted by Dr. Blumenfeld on American Headache Society member physicians aimed toward identifying the indications for occipital nerve block, and they find that occipital nerve or notch tenderness, occipital headache, neck pain, frontal headache, supraorbital or infraorbital notch tenderness, and neck muscle spasm is a good indicator for greater occipital nerve response. So what is the proposed mechanism? Nerve blocks involve injections of local anesthetics around the peripheral nerve branches, and prolonged analgesia is obtained due to the central pain modulation. The mechanism is based on blocking the sensory nerve fibers with local anesthetic in a very low concentration. So local anesthetics bind to sodium channels through C fibers, sparing motor fibers and prevent pain signals carried by C fibers. The diffusion of local anesthetic is related myelin thickness, and low concentration anesthetics tend to diffuse C fibers, sparing the motor A fibers. Which local anesthetic do we have to use? Expert consensus medications include the use of 2% lidocaine and 0.5% bupivacaine. If a combination of two drugs is used, the recommended volume is 1:1, and different doses have been used in different studies, but the commonly used doses are 1:1 mixture of 0.5% bupivacaine and 2% lidocaine, totally 2 milliliters. The combination of lidocaine and epinephrine reduces vascular permeability along the nerve and minimizes systemic toxicity. And the use of epinephrine also increases the duration of the analgesic effect of lidocaine. What about the choice of steroid? It's a discretion of the clinician, but the most commonly used are triamcinolone 40 mg, methylprednisolone 40 to 80 mg, and betamethasone 16 mg. There are conflicting results regarding the addition of corticosteroid in migraine, but there is evidence to support their efficacy in cluster headache. So steroids reduce inflammation and prolong the duration of the efficacy. As recommended in many studies, we use a total 2 ml of 2% lidocaine plus bupivacaine and 80 mg methylprednisolone for greater occipital nerve block. Single or repeated injections of GON block may be used in different studies. So treatment intervals and drug used for GON block remain a matter of debate. The duration of response to nerve blocks varies considerably between patients, ranging from weeks to months, regardless to the type of headache. In some patients, single administration may provide benefit for months, while in others, it may be necessary to repeat at weekly or monthly intervals. So in case of recurrence, we don't use steroid for less than 3 months. The most frequent side effects of greater occipital nerve block include pain at the injection site and numbness. Lightheadedness and syncope may also occur, as well as local hematoma, local injection, and nausea. Skin atrophy, hyperpigmentation or hypopigmentation of the skin, and local alopecia have also been reported when used with steroids. However, nerve blocks is safe and well tolerated compared to other treatments and their side effects. Contraindication of greater occipital nerve block are infection and malformation such as hemangioma at the injection site and allergy to anesthetics or steroids. The patient is monitored for bleeding after the procedure, and patient is monitored at least 30 minutes in the outpatient clinic after the first injection, and is not allowed to drive a car after the procedure for 4 hours. The blood pressure and the heart rate is checked before and after the procedure.